So we treat chronic venous disease because it has complications and affects the quality of life of our patients. Axial reflux is identified and treated, and then we eliminate the abnormal tributaries. Large caliber tributary veins risk phlebitis and thromboembolic complications. This can be quite uncomfortable, and obviously DVT and pulmonary embolism have a lot of morbidity. So we employ techniques to ablate the axial reflux. Once the elimination of the reflux is achieved, it reduces the venous hypertension, causes regression of the tributaries, and improves the clinical status just by addressing the reflux. We then use microphlebectomy to eliminate the abnormal tributary veins. These tributary veins, particularly when they're large, as I said, put the patient at risk for phlebitis, and they can be associated with both symptoms themselves as well as recurrence and progression of disease. So ablation and phlebectomy are usually employed on most of our patients. Concomitant and staged approaches are options that we have to apply to these circumstances, and they have advantages and trade-offs like a lot of the controversies that we discuss. With concomitant approach, it's a single episode of treatment, one recovery for the patient. The phlebectomy is performed immediately after the ablation is achieved, and this results in a slightly longer procedure time depending upon the extent of the phlebectomy. Here you can see a nice, neat situation. Posterior medial branch of the greater saphenous vein is ablated, and some large caliber veins are removed at the same time. But applying this to more extensive veins as a strategy becomes more arduous for the patient and even for the physician. An ambitious combined procedure is going to take on more time and mandate a longer recovery for the patient potentially. So we have to be selective in how we apply these things. A staged phlebectomy strategy involves doing the ablation and then having the patient come back for their follow-up ultrasound. And at that time, you have an opportunity to reassess the veins. Over time, once an ablation is performed, typically the veins will regress to some degree. And many of the patients that I take care of need multiple ablations and multiple phlebectomies depending upon the area that's serviced by the trunk vein. So the time in between the initial ablation and when I get to do a phlebectomy can be a couple of weeks, and again, ample time for regression. This photograph on the right is the pre-ablation photograph of a patient I just took care of actually on Wednesday. So this is her post-ablation, multiple weeks later picture. And you can see that the varicose veins have regressed. Now, is it complete, partial, or is there no regression? We have to ask that question when we evaluate these patients. What is the symptomatic status of the patient, and is there a thrombosis risk? Obviously, with this, it's a dramatic improvement. But with using transillumination and evaluating the leg, there still were large veins there, so she underwent a phlebectomy, but the scale of that, the scope of that phlebectomy was much less than it otherwise would have been. On the left is a nice, neat presentation, small saphenous vein reflux and a cluster of veins, easy to do. On the right, you can see this would be a much more involved combination of ablation and phlebectomy. Looking to the literature for some guidance, the Avulse study compared concomitant versus staged phlebectomy after ablation. And basically, clinically, by the time you got to 6 months or a year, the patients were the same, but there was an initial benefit of some symptom relief when both were done together. But 64% of the patients that they studied didn't even go on to need a phlebectomy, so regression was significant. They did not emphasize that, but that was their data. Can phlebectomy be deferred in the treatment of varicose veins? This was presented at AVF. And again, clinically, at about 6 months to a year, the patients were equivalent, and many of the patients did not require a phlebectomy. Another study from JVS in 2020, over 3,000 patients from the varicose vein registry. Both approaches were deemed to be safe and effective. And again, a lot of the veins regressed. Here is a study with EVLT comparing the two approaches, and they mentioned that, again, both approaches were acceptable, and again, regression of the veins occurred. And this study out of Baltimore in JVS talked about EHIT being slightly more common with a combined approach, but most of these were pretty insignificant EHITs, and there were no pulmonary emboli. So when I look to the literature in search of which direction to go or what method is better, basically both of these are sound ways of approaching patients. And when the scope of the procedure can be managed where it's not overly arduous, maybe you do them together, particularly if the veins are large. But basically, for me, in my practice where we're trying to keep a schedule going, I like to work smart and not hard, so I'll often allow for regression. So when the veins are discrete, like on the left, this could be, either approach could be applied, depending upon physician preference. On the right here, I would do a concomitant approach, and I would get rid of the veins in the thigh because that's a significant risk for phlebitis. But you can see there is extensive veins down below the knee. I think I could adequately compress those and wait for a second phlebectomy. Again, the middle and the image on the right of the patient I already presented, that's a dramatic improvement following ablation. But on the left, this is a very large collection of veins, and you might do them all together, but that's going to be a phlebectomy that's going to take a long time with your ablation. When there is veins on multiple surfaces, this patient had veins anteriorly associated with the greater saphenous. Those can be done together, but the veins on the back, I'm not going to turn the patient over, so some patients have multiple phlebectomies, and I would use a staged approach. I presented this picture a few minutes ago, and for this, I feel like if I left those veins in place, they would invariably thrombose. So for me, when the tributaries are manageable, I would do a concomitant approach. So the advantage is that large proximal tributaries can cause phlebitis, and we want to avoid that. If the grouping of tributaries is discrete, it's easy to do. If the provider emphasizes an all-in-one approach, you can go for that. But and the patient, they talk about, in these articles, we ask the patient what they want. Well, every patient wants everything done at once, so those data are really not very valuable to me. And again, managing your schedule and your energy is important. Here's another obvious patient that could be handled either way. I would probably do this staged, but doing it together is fine. Those are big veins. And I counsel the patient on the strengths of both approaches. Here's a patient that would be very difficult to do, take care of all those veins at the same time as a phlebectomy unless one wanted to commit to a very long procedure. She had veins like this on the front and back of her legs and had a great outcome, but it was done in a staged manner. And as I said here, this would not be an easy recovery. So you want to, with the staged approach, you minimize the recovery, you assess for a low risk of thrombosis, and I can combine concomitant and stage approaches when it's extensive. Here again is a very obvious one for this strategy, but as it gets more difficult, you have to ask yourself as the physician, and the physician quality of life, do I like doing these huge cases during the day, and does it disrupt my schedule when I can do a different approach that maybe is easier for the patient and for myself? So in summary, ablation and phlebectomy are usually both required. The literature shows, and my experience as well shows, that veins will regress. Both approaches present advantages, and I don't think you have to be locked into one or the other. This is not a thing you have to choose as a controversial part of your practice. I think understanding the merits of both approaches gives you lots of options for your patients and for yourself. Thank you.